I'm really deeply honored to speaking in line with the pioneers of thalassemia clinical research from the colleagues from the UK and Italy, whom we've just heard before. So I've been given the task to talk about gene therapy and gene editing. Gene editing is, of course, a part of gene therapy. But anyway, we have been involved in that, in particular in the context of gene addition gene therapy, and in Heidelberg, where we have now treated 9 patients with that, but I will get back to that in a minute. So what would be the current standard of transfusion-dependent beta thalassemia major? And we've heard a lot of details about that in the earlier session. And of course, the standard is red cell transfusions and iron chelation and the interdisciplinary care that we have been hearing about this morning. Alternatively, if an HLA-identical donor is available, it would be allogeneic hematopoietic stem cell transfer, also generally referred to as bone marrow transplantation, where obviously you first have to have a donor that is suitable with the HLA type, so with the blood group, if you wish, that determines the immunological tolerance and the compatibility between the donor and the recipient. So if that is then secured following a complicated process and also sometimes a painful process of conditioning, so wiping out your own bone marrow and then replacing it by the new bone marrow, giving that, after having given that to the recipient, all going well, the blood cell production will be taken over by the bone marrow of the donor, so therefore obviating afterwards the need for blood transfusions. So why then, if that is all possible and this is all standard, why then are we talking about gene therapy? And I think one of the reasons are data that have been generated by the European community, the European Society of Bone Marrow Transplantation, the EBMT, and this is shown here, that actually while matched sibling donors, so this is the type of donors that I've been referring to. Oops. Okay. How do I do this? Do it that way. Most of you are here. So if you look at sibling donors and matched donors, you know, the prognosis with event-free survival here and the time showing on the bottom is actually quite all right. However, if you are using donors and in a non-matched setting, which is technically also possible with some precautions that one has to take, still the prognosis and the outcome of these alternative transplantations are not so great. And when the EBMT register updated their numbers for a presentation at the ASH meeting, at the meeting of the American Society of Hematology a couple of years ago, we can still see, and that's on the right side of that graph, is that haploidentical, the transplantation from haploidentical donors only gives a good outcome in 70 to 80%, which would be acceptable in some forms of leukemia, which of course is an acutely life-threatening disease, might not be such a great number for diseases that are not acutely life-threatening and giving you that sort of morbidity and mortality at the end of the day. So that motivated people to develop gene therapy, basically under the general principle that the patient, him or herself, would give his or her own stem cells, so that which would be mobilized by a specific procedure, would be harvested by a procedure called apheresis. So this is the step 2 here on that graph. And then the stem cells, the CD34 positive cells, would be selected, and then the gene therapy vector, which is basically a derivative of a virus that can then infect these stem cells and can, as a cargo of that virus in a gene transfer, establish normal red cell hemoglobin production or beta globin chain production specifically to actually create a normal hemoglobin at the end of the day. And then following this preparation, which is very similar to allogeneic transplantation, so coming from another person, would then be transferred to the patient, him or herself again, hopefully reestablishing normal red cell production. So that's how it works in principle. The advantage is that you do not need somebody else as a donor, so you can act as your own donor, so to speak. The advantage is also that the discrepancy in the immune system between the donor and the recipient does not, of course, play a role because it's yourself. However, there are some other challenges with this gene therapy that have to do with the integration of the new genetic material, if you wish, into the genetic makeup of the recipient. Anyway, so how does that work? And these are data that have recently been published in what people call a swimmer plot. And on the left side, you see the results of 21 patients that have recently been published, and the dark blue is the time. I should explain. On the left, you see the patient numbers, and on the bottom, on the x-axis, you see the time of follow-up, and the dark blue reflects the time that people do not require a transfusion, and the light blue reflects the time that people require transfusion. So what you can see in essence here is that 20 of 22 patients treated in that way have become transfusion independent, and that, of course, is the average hemoglobin. 1.7 is, of course, a mistake. I only now notice now it's 11.7 gram per deciliter, and the actual hemoglobin coming from that vector that I've been mentioning is 8.7 gram per deciliter, which obviously, as you all know, is substantial. And if one takes together two different studies in different time frames, and that is showing you a similar swimmer plot with a larger number of patients, we see approximately 90% efficiency, meaning that 90% of patients who have been treated have remained transfusion independent, now with follow-up times of, in some patients, more than 5 years. So how does that work in principle? This is just showing you a schematic representation of such a vector. That is a little complicated, but I'll just point out the relevant parts. These black building blocks that you see in the left scheme on the top are sort of necessary DNA sequences that the virus sort of needs to get into the cell and to release the cargo, and the cargo is a beta globin gene that is regulated by the regulatory DNA sequences that it would normally also use in the context of one's own genome, as one is called the genetic makeup. So this is effective in beta thalassemia. In total, there have now been, as far as I know, 63 patients with a mean follow-up of more than 3 years have been treated, and in the context of beta thalassemia, there has been no evidence of oncogenic insertion mutagenesis, which means that the insertion of these vectors have not, one could say so far, within the time of the follow-up that is available, have not resulted in cancer. And most importantly, all of these 63 patients have survived, so there has been no patient who has died following the procedure. So that's good news. However, when looking at sickle cell disease, same treatment. There have been 2 patients who have developed acute myelogenous leukemia, a life-threatening disease. In one patient, the vector that I've just described has not been found in the actual cells that gave rise to the leukemia. So the conclusion, I think, with good reason, was that the gene therapy as such has not been the reason for that leukemia. However, the gene therapy as such comes with this chemotherapy that prepares a patient for the uptake of his own bone marrow, and this treatment is done with drugs that are well known to cause secondary leukemia in a small digit percentage number. The second patient, so taking that as a whole, the whole procedure, well, cannot be considered as completely harmless, but allogeneic transplantation would not be either. So this is, one has to compare the different procedures, of course. Then the second patient was a 24-year-old female who, after 5.5 years, after having received the gene addition therapy for thalassemia, has developed an insertion, and the leukemia has actually developed in cells that also contain the new genetic material. However, it has integrated into a site of the genetic material that has not actually in its surroundings been altered in its behavior, in its gene expression, and the neighboring gene where this gene vector has been integrated is not known to be associated with any malignant disease. So this has been interpreted that the vector integration has not been causal for the development of the leukemia, but it has been interpreted to be related to some specific features of the sickle cell disease causing oxidative stress in the cells, but there's no direct evidence for that. This is an interpretation, and it's an assumption. But if you compare that to the outcome of allogeneic transplantation and sickle cell disease, you also see malignant diseases, leukemia in particular, developing in a small digit percentage after allogeneic transplantation. So this may well be not specific to the gene therapy, but that, I think, at the present time is still an open question. Right, I will not be talking about the details of the left part of this figure. That will take us too much into the details, I suppose, but I'm happy to discuss that at the end. So gene editing. So what I've been talking so far about is that you take a normal beta globin gene, put it into these vectors, put it into stem cells of a person with sickle cell disease or with beta thalassemia, and then the new genetic material is sort of replacing the lacking activity of the existing genetic material, and this is referred to as gene addition therapy. So the alternative is gene editing. What does editing mean? That basically means that you are changing existing genetic material in the blood or in the stem cells of a patient by a manipulation of a genetic manipulation coming from outside. So how does that work? In principle, editing means that an enzyme that is known from bacteria, which is basically the immune system of bacteria, chopping viral sequencing that enter the bacteria up. So that's an enzyme called Cas9. You may have read about that. And this enzyme Cas9 can be guided to specific sequences. So this is in the middle, this panel B shows you Cas9 with the guide RNA, so it can be homing in on a specific site in the big haystack of your genes and can then cause a cut. This cut is sort of incompletely and incorrectly repaired, so basically inactivating the target gene that has been targeted by the guide RNA, so directing the protein, the enzyme that is just cutting the DNA at that point. So basically destroying it. So you might wonder, well, why do I want to destroy something to actually get a therapeutic effect? And that is another interesting point, and that is shown on the left side of that slide, is that, of course, we are having a fetal hemoglobin and we're having an adult hemoglobin. And the difference between the fetal and the adult hemoglobin is that the fetal hemoglobin does not contain beta globin, and that is the chain, as you all know, in thalassemia and also in sickle cell disease that's affected. It makes gamma globin. And this is also why both patients with sickle cell disease or with thalassemia are born healthy, right? So there's nothing wrong in the young baby. The problems only arise after the fetal gamma globin chain is inactivated in its expression and the adult beta globin gene is activated. And if the beta globin gene that's activated is not working, of course, you have a problem. So there is a protein that is governing this process of silencing the gamma globin gene and activating the beta globin gene. And this protein is called BCL11A. And if we inactivate this BCL11A gene, this switch of the gamma to the beta globin gene can be inactivated or can even be reversed in adult life. So this is the principle of the current methods of gene editing, that this BCL11A gene is inactivated, allowing the healthy gamma globin gene expression to re-emerge and fetal hemoglobin being produced. And by and large, fetal hemoglobin, with some details, but by and large, fetal hemoglobin is a functional hemoglobin even in adult life. So these are the first two patients shown on the right here, where this has been published for the first time last year, that this principle works both in sickle cell disease and in beta thalassemia, and working in that case means that the fetal hemoglobin increases. So these are recent data that have been presented at the very recent meeting of the European Hematology Association just a couple or so weeks ago, and this strategy has now been used in 44 patients with transfusion-dependent thalassemia and in 31 patients with sickle cell disease. And here again, you see the swimmer plots. On the left, there are the beta thalassemia patients, and again, everything that's dark blue means transfusion independence. And on the right, with sickle cell patients, that means the absence of vaso-occlusive crisis. So this gene editing strategy also appears to be working, which is good news, of course. But some of you may have read that, you know, these gene scissors, this Cas9 is sometimes referred to, is great because it only does something at a very defined spot. So this is highly specific. We do not have insertional mutagenesis. We do not have problems with that. So this is just a surgical procedure of correcting a gene, or in that case, inactivating a gene, and then allowing something good to happen. But is it really as safe as it is sometimes assumed or sometimes being portrayed in the press? Well, maybe not quite, because there's a process called chromotripsis. And that is a process that we only know about now for just about 10 years. And that is a process where a chromosome can be completely destroyed and reassembled in a random way. So this is sort of in this in this picture here that are actually gleaned from Wikipedia, which I thought is really nice. So on the top you see a normal chromosome with its bits and pieces in an orderly fashion, sort of shown here by the colors. And then there is what one calls a single catastrophic event in the cell history, and this chromosome is shattered and then repaired, but the bits and pieces are sort of coming along in different ways. So at the end of the day, there is a chromosome that is highly abnormal, and it is known that this process of chromotripsis is one of the major drivers of cancer of all sorts, in principle. So what does chromotripsis have to do with gene editing? There has been a study published last year firstly in cell lines, but then also in CD34 stem cells of people. And they have been using this BCL11 gene editing to treat, if you wish, these cells. And what they found, and this is shown here, that chromotripsis is actually happening in these stem cells with exactly the same procedure gene editing is being used for. And this is not a rare event, and this is shown on the right here. This is micronucleation rate, which is sort of a surrogate marker for chromotripsis, and this is happening in 5 to 10% of the stem cells. This has not yet been okay. That's basically showing the same, so I'm skipping that. So the higher the editing efficiency, the more of these chromotripsis events are being induced in the stem cells. So far, one has to say, in patients who have been treated with this gene editing, nothing had happened, but cancer to develop can take a number of years. So it's probably early days to just lean back and say, okay, that's safe, nothing has happened. One has to say, okay, nothing has happened so far. And that is true for both types of therapies, also true for the gene addition, because insertion mutagenesis can also have its effect of up to 10 years or so, probably after the treatment, and that may also be the case for gene editing. So this is just a mention of caution, a mention of being a little bit circumspect about it, but on the other hand, of course, gene therapy is a great option, and it has now been used taken together in approximately 100 or so patients, and so far it has really been met with great success in the sense that approximately 90% or so of these patients have been cured from their disease. So that's of course very good news. And the advantage of both types of gene therapy is that this graft versus host disease, which is a disease that comes from the immunological differences between the donor and the recipient, is of course not a problem because one is using one's own cell, and immunosuppression that must be used following allogeneic stem cell transplantation is of course not a problem in this type of disease. And so far there has been a favorable safety profile. I've mentioned that so far nobody has died as a result of that therapy, but as a note of caution, even though 100 patients have so far been treated, the numbers are still limited, and also the time of follow-up is also limited. So, and also I've been explaining to you the potential safety issues which may be related to pre-existing leukemic clones, insertion mutagenesis, and the induction of chromotripsis, although these are at this time theoretical notes of caution, but I think it's still worthwhile to take those into consideration before we are becoming all over enthusiastic. But having said that, we are accepting allogeneic transplantation, so coming from a different person as a standard way of treating, and we also know that these types of treatment can also result in serious problems, and so we, in the long run, we'll just have to compare this. I'd like to thank you very much for your attention.